Thank you. I have two cases. The first one is about an 89-year-old male that was presented with dyspnea and New York Heart Association Class 3. He also had an episode of pre-syncope. He suffered from chronic obstructive airways disease. He had severe aortic stenosis with a maximum pressure gradient of 106 millimeters of mercury, and the aortic valve area was 0.65 square centimeters. He also had left carotid artery stenosis. The logistic Euroscore was 26. A week before TAVI, he presented with GI bleeding, and with the capsule, he was diagnosed as angiodysplasia of small intestine. His hematocrit was 24.5 and was transfused with 2 units of blood. This is his ECG before the TAVI, and this is his TOE. There was a question about if the valve was a tricuspid or bicuspid. In the TOE, we thought it was a tricuspid one. The CT, we didn't actually thought that it was a bicuspid, but at the end it was proved that it was a bicuspid. And that make it more difficult. This is the procedure. We decided to put an Evolut Pro 29. And this was the first attempt. The valve was, although we started high, it was diving in. And that is one of the characteristics of the bicuspid valves. Then he had to recapture the valve and try a second time. We started even higher, but again, it was too deep. So we tried third time, and despite our attempts, the final position of the valve was low, and there was significant aortic regurgitation. We decided to tackle initially the problem with putting a balloon, and we did a balloon expansion of the valve, and despite that, that didn't improve the regurgitation. So at that stage, we decided to put a second valve in. It was first. It was quite difficult to cross the stand of the first valve. The second valve was capturing and bending the stand of the first valve. We managed to do that, and then during the first attempt, it was again the second valve too deep. Also, it was very difficult to separate the frame of the second valve from the first valve. We have to do a lot of cines so we can appreciate where the second valve was. Again, on the second attempt of the second valve, it was again deep. And on the third attempt, we thought that we were at the right spot. And you can see at the release that the height difference, you can appreciate the height difference of the second valve from the first valve. And there was only mild aortic regurgitation now. The second valve has sealed the regurgitation. And at the end of the procedure, we had also a rupture of the iliac, which we treated with an iliac balloon, and that sealed the leak. This is the TOE post. You can see there is only a mild aortic regurgitation. The ECG after TAVI increased the QRS, but 2 days post-TAVI, the QRS, the ECG was back to the initial one. 2 days transthoracic echo showed that there was no aortic regurgitation anymore, and there was an acceptable gradient across the two valves. The antithrombotic regime on that patient was subcutaneous heparin because of the angiodysplasias. He had the mild hemoptysis 2 days after the procedure, and we did a CT of the thorax, which showed the hematoma of the trachea due to intubation. He was transfused again with 1 unit and discharged on day 8. Post-discharge, now a month later, he didn't have any further blood loss, and he remains well. Should I proceed to the second case or not? Okay, the second case is a 79-year-old female, recent episodes of pulmonary edema, previous AVR with Magna Edwards, 21, and a Lima 12 AD. She also had anemia with hematocrit of 22. Again, she had angiodysplasias of the small intestine. There was severe degeneration of the aortic valve, pulmonary hypertension, and there was a moderate stenosis of the right coronary artery. The Lima was patent. This is the angio before. You can see there is actually a free AR. It's like there is no valve in the position of the aortic valve. We start deploying the Evolut R. And this is the final deployment. And you can see you can appreciate the hemodynamics that the pressure of the aorta and the LV were quite similar pre, and also how the aortic valve, the pressure of the aorta became later. And in the TOE post, you can see that there is no aortic regurgitation. She was again treated with subcutaneous heparin, and 1 month post, her hematocrit was 37.3, and the heparin was changed to oral NOx. Thank you.
Thank you, Dimitris, for the difficult cases. Are there any comments?